how do we test novel combinations? How do we address special populations that may not be benefiting as well from immunotherapy? So for instance, patients with liver metastases do poorly with immunotherapy across the board, irrespective of the solid tumor type. In particular, patients with liver metastases have shown very poor response rates in the range of 8 to maybe 15% based on what study we look at. Also, there are patients who have FGFR3 mutations. There's some evidence to suggest that these patients don't do so well with immunotherapy. I think this is somewhat of a controversial thing, but nonetheless, we'll have to address these patients as well. And then moving forward, what is the role of CTLA-4 blockade in advanced bladder cancer? We are seeing evidence from phase 1 studies testing the combination of CTLA-4 plus PD-1 blockade showing improved responses, even in patients with very high levels of PD-L1 expression as well as low levels of PD-L1 expression. And there are trials now testing that combination in metastatic bladder cancer in the first-line setting. Similarly, we also have to define what is the role for combination immunotherapy with platinum-based chemotherapy. There are 2 very large randomized trials testing that in a randomized setting in first-line bladder cancer. What many of us in this field expect to see is that platinum-based chemotherapy plus immunotherapy will be the new standard of care for all patients with advanced bladder cancer. That will still not address, how do we treat patients who are just not eligible for chemotherapy. I think for those patients, immunotherapy on its own will still have a major role, perhaps as single agents or perhaps as combinations, and certainly our older individuals who simply can't tolerate chemotherapy. I think that's an important therapeutic option that we still should investigate.